Welcome everyone to the Spring Yerby Diversity Lecture in Public Health. I'm Michelle Williams, Dean of the Faculty here at the Harvard T.H. Chan School of Public Health, and I'm delighted that you've joined us today. The Yerby Diversity Lecture Series is an opportunity to highlight the accomplishments of minority scholars and public health leaders. This lecture series is named in honor of Dr. Alonzo Yerby, an African-American public health leader, a graduate of our school, and a member of our faculty. Dr. Yerby was the first African-American department chair at the school and an associate dean for community affairs. I am pleased to welcome our distinguished speaker today, Dr. Lisa Cooper, our 16th speaker in this long-standing series. Dr. Cooper is the James F. Fries Professor of Medicine and the Bloomberg Distinguished Professor in Health Equity at Johns Hopkins University School of Medicine, Nursing, and the Bloomberg School of Public Health. A Liberian-born general internist, social epidemiologist, and renowned thought leader on health disparities, Dr. Cooper is also an award-winning educator and mentor. Her research focuses on racism and the socioeconomic factors that shape patient care and how patients and health systems, together with communities, can help populations with complex social needs. She has authored over 200 publications, including the forthcoming book entitled, "Why Are Health Disparities Everyone's Problem?" Dr. Cooper has served as the principal investigator for more than 20 grants from the National Institutes of Health, the Agency for Healthcare Research and Quality, the Patient-Centered Outcomes Research Institute, and numerous private foundations. She is the founder and director of the Johns Hopkins Center for Health Equity, where she and colleagues work in partnership with health systems and community-based organizations to develop and test interventions that alleviate racial and income disparities and translate knowledge into sustainable practice and policy changes that advance health equity locally as well as globally. Dr. Cooper has led the Johns Hopkins Urban Health Institute with the mission to advance health and health equity in Baltimore. She has received several honors for her important work, including a 2007 MacArthur Fellowship and membership in the National Academy of Medicine, American Society for Clinical Investigation, and the Association of American Physicians. She is recipient of the Herbert W. Nickens Award for outstanding contributions to promoting justice in medical education and healthcare equity from the Association of American Medical Colleges, and the Helen Rodriguez Trias Social Justice Award from the American Public Health Association. Dr. Cooper received her Bachelor's of Arts in Chemistry from Emory University, her medical doctorate from the University of North Carolina at Chapel Hill, and her Master's in Public Health from the Johns Hopkins Bloomberg School of Public Health. Today, Dr. Cooper will speak on advancing health equity using evidence from community engaged interventions research to transform practice and policy. Her lecture will describe the concepts of health disparities, health equity, and social justice, and will expose the audience to studies using transdisciplinary research methodologies to better understand and overcome local and global cardiovascular disease health disparities. Today's moderator is Dr. David Williams, the Florence Sprang Norman and Laura Smart Norman Professor of Public Health and Chair of our Department of Social and Behavioral Sciences here at the school. Dr. Williams, as you all know, is also Professor of African and African American Studies of Sociology at Harvard University. Please join me in giving a warm welcome to Dr. Lisa Cooper. Dr. Cooper, over to you.
Thank you. Thank you, Dr. Williams. And it's a pleasure to be with you. And I'm honored to be your Yerby lecturer for this year. So I'm going to share my screen. So as Dr. Williams mentioned, I'm going to be speaking to you today about using evidence-based community-engaged interventions research to transform practice and policy as a way of advancing health equity. So these are the lecture objectives. We're going to, as she mentioned, we're going to discuss some key definitions and frameworks that inform disparities research, discuss some of the gaps in evidence, and highlight transdisciplinary research methods. We're going to touch on how the COVID-19 pandemic has highlighted the larger pandemic of disparities in health, and then conclude with recommendations for advancing health equity through research. So I want to tell you how this all began and where it all began, my passion and my interest in doing work related to health equity. I was born and grew up in Liberia, West Africa. It's a small country on the West Coast that was basically started by freed slaves and free Blacks who left the Americas in the mid 1800s and early 1800s actually, and returned to Africa in search of freedom and a better life. And so they established a country called Liberia through an agreement with the indigenous people who were living there at that time, Liberia meaning the land of freedom. And so on this slide there, you see my parents, and I think I had a very happy childhood. My parents were professionals. My father was a physician, and my parents established a hospital, a small hospital. That's the picture you see up in the right-hand corner, called the Cooper Clinic. And my parents were very much interested in serving community. And so through their work and their service to community, because were involved in other organizations where they did things like promote adult literacy and prevent spread of leprosy, for example. They showed my brother and my sister and I, and that's us in the lower right-hand corner, the importance of service to community. They taught us that to those whom much is given, much is expected. So I grew up with a sense of knowing that I wanted to give back to my community to make it a better place. And also our parents also taught us a lot about the importance of family and relationships. Family is very important in Liberia. We have large extended families there that we all know one another. So we grew up with that background. But on the other hand, not far away from where I lived in a pretty comfortable home, there were lots of people around me who weren't so fortunate. They lived in homes that were made of mud, oftentimes dirt floors without running water. I saw a lot of people who were poor and a lot of children who didn't go to the nice school that I went to that had all the different equipment and well-trained teachers. So what I always knew on some level that didn't seem right. And I think what I always envisioned was a world where all those children would have the same opportunities to live a full life and to be as healthy as I was. And so I think what I was envisioning back then, even though I didn't have the words, was social justice, which is really fairness in the distribution of wealth, opportunities, and privileges within a society. And it's a situation where a society protects its least advantaged members. So while I was envisioning that, one thing I realized was that I didn't know this at the time, but I had heard a lot of things said about Dr. Martin Luther King. And one of the things I learned more recently was that when he wrote his letter from the Birmingham City Jail in April of 1963, one of the things he said in that letter was that injustice anywhere is a threat to justice everywhere. And the coincidence that I learned from reading this was that he actually wrote the letter on April 12th, which was actually the day that I was born. So I often say that I think I came into this world with some sense that I wanted to do something about injustice and to promote social justice. So how did I want to do this? I really focused in on health early on. I think a lot because of my role models, my father being a physician, my paternal grandmother was also a nurse. So I was really kind of interested in science and in health. And so I think what I wanted to do, even though I didn't have the words for it back then, was to move us from a situation where we have health disparities, which are these preventable differences in illness and disease and opportunities that are experienced by disadvantaged populations, And I wanted to move us to a place where there is actually health equity, where everyone has the opportunity to attain their full health potential and no one's disadvantaged from that based on their social status or socially determined circumstances. I left Liberia actually as a teenager, and I was in boarding school in Europe, but actually ended up going home for spring break. And on my 17th birthday, the government was overthrown. And that was the year I was graduating from high school. So I sort of had to leave Liberia under very stressful circumstances. And I now know that the civil unrest that took place there was in large part because of the disparities and the inequities that existed within our society there, that there were people there who felt that it was very unfair and they were not happy. And that led to a lot of the unrest that led to the political instability and overthrow of the government. But fast forward, I left Liberia that year under some stressful circumstances, coming to the United States to go to college, and went to Emory University, where I pursued my training in pre-med actually training, and did my degree in chemistry. But then after that, decided that I was going to continue to pursue my lifelong dream to become a physician, and went on to medical school. And when I was graduated from medical school, I moved to Baltimore, Maryland. My family was living in the Maryland area at the time, and did my residency at University of Maryland Hospital. And at that time, it really became apparent to me that health disparities were here in the great United States of America as well. I saw patients who were poor. I saw patients who were struggling with things like not being able to get a good job, not having access to safe housing. They had fallen on hard times. Many of people had turned to use of drugs because of their despondency around their social situation. And lo and behold, I was seeing a lot of the things that I saw growing up in Africa. And this was actually at the peak of the HIV/AIDS epidemic. And there was a lot going on there with drug addiction and a lot of the kind of social ills that we know plague people who are poor and who don't have access to opportunities. So I saw that and I thought, I really want to be a good physician, but I felt like I needed to be able to work on a broader scale. And one way to do that would be to get further training in public health and, and see what I could do with that. And so I went over to Johns Hopkins to do a fellowship and do my training in public health, thinking that I was going to go into public health practice, but got bitten by the research bug. And here I am some 25, 30 years later, still working in this field, because I realized that the problems that I was seeing in the largely African-American population in Baltimore, those kinds of problems weren't being studied by a lot of people. They were being studied by some people, but some of the questions I had around why people were in the predicament they were in and how we could do a better job of treating them were not being asked by the researchers. And so the only way to get answers to some of those questions was if people like me got involved in the research. So lo and behold, where I see patients now is in the Madison East End neighborhood of Baltimore. That's right there where you see that Hopkins dome. It's that neighborhood surrounding Johns Hopkins Hospital. And I show this slide often to show that just in a 5-mile radius, there is a 20-year gap in life expectancy between those two neighborhoods, Madison East End, where I see patients near Johns Hopkins Hospital, and Roland Park, where a lot of the Johns Hopkins faculty members live. You can see that there's a difference in the racial profile. The income level is about 3 times higher in Roland Park. Unemployment rates are low. Homicide rates are low. And in contrast, you see right in Madison East End, not that far away. So this really gives you an idea of, kind of the impact of these differences in social determinants that, you all study in public health every day around, safe housing and opportunities, economic opportunities, educational opportunities, the social environment in terms of things like crime, access to healthy foods, all those things and how they shape opportunities as well as health. So, everyone knows that health disparities are pervasive across numerous conditions and that they impact all of us because of their impact on costs, quality of life. In large part, the people who experience health disparities are people of color, people with lower levels of income and education, and often people who have either physical or mental disabilities, as well as, people who are immigrants. So we just added to this list COVID-19 this year. And for those of us who do work in this area, of course, this was no surprise. So we'll talk a little bit about that later. But first, let's talk about, what causes health disparities. And I know you all hear a lot about this in your lectures, but of course, they result from complex interactions among multiple factors, all the way from social conditions and economic policies, the physical environment, as to institutional factors, including in the healthcare system, to social relationships, and also then to individual risk behaviors and biology. And so, one of the reasons it's been so complex to address health disparities is because they are so complex. And, as physicians, oftentimes we used to in medical school really focus on the individual behaviors and biological factors, but I really felt that we were missing out on a lot of the broader factors that we address in public health. And one of the reasons for my motivation to go into public health was to gain a better understanding of some of these complex interactions. But one of the things that wasn't being talked about a lot was, the fact that these broader kind of structural factors and cultural attitudes actually shape how these factors are distributed across different populations in our society. And thankfully, I think now we're having a much more open conversation about issues like racism, which actually shapes the opportunities that people in these different groups have, through the sort of pervasive attitudes and behaviors and support for different policies that have occurred over generations and generations, and have actually shaped where people live and their access to all these different resources and opportunities. So all the isms are the factors that really shape all these other factors. And so we really have to understand those factors too, and really understand the historical context as well as how these factors play out in our current environment. But we can't tackle everything, right? Not all at the same time anyway. So for me, early in my career, being a physician, I really wanted to focus on the health system factors because I felt like that was someplace that I could actually, I understood pretty well, and I felt that I could have an impact. I felt like if people have inequities in our larger society, at least when they get sick, they shouldn't be experiencing disparities in the quality of care we deliver, and that we should at least be striving to provide care and access to it to everyone who needed it. So I really wanted to focus on that. I also, because of my strong focus on relationships in my upbringing and my keen sort of interest in building stronger relationships with patients, really wanted to focus on the role of relationships, social relationships, between doctors and patients, between other health professionals and patients, between physicians and their community members. So I was really interested in understanding how social interactions and relationships shape health disparities. So that really sort of shaped the trajectory of my work. So, I started out studying patient attitudes and beliefs, but then quickly realizing that patients really talked a lot about how important it was for them to trust their physicians and to have someone who actually understood them and treated them as a person. And so I really quickly transitioned into studying doctor-patient relationships. And one of the things we found in our early work, we used surveys as well as studies where we audio recorded visits with doctors and patients. And we found that compared to whites, African Americans and Hispanics experienced not only lower levels of trust in their physicians, but also less participatory visits. That means that they were less involved in making decisions about their treatment, that doctors tended to dominate the conversation, to just talk more. They were verbally dominant, talking about 75% more than Black patients, and then about 50% more than white patients. So doctors talk too much overall relative to patients, but they definitely dominate the conversation more when talking to patients of color. that the visits sounded less friendly to people who were independent coders of those audio recordings, and that there was less rapport building conversation, less conversation about things like home and work and children and other issues that might be bothering people, and really a more strict focus on the medical issue. We also became interested, me in particular, because I felt that, one thing that might help to address this is if there was a better connection between the doctor and the patient. So I wanted to know whether race mattered, of the race of the physician. And so we studied race concordance. And we actually found that when doctors and patients share racial background, that the visits were a little bit longer, about 2.5 minutes, that there was more participation in the visit by minority patients, that both the doctor and the patient sounded happier, and the patient rated the visit as being more satisfactory. So, so what did that tell us? I mean, it wasn't really surprising, but I think what was concerning is that, health professionals should be able to treat all patients with the best quality of communication, and that we shouldn't really be communicating differently with patients based on whether we share social, background with them, even though that's understandable. So, and I also knew though that most physicians weren't doing this intentionally, because we had asked physicians about their attitudes, at least their explicit attitudes towards patients of different racial and ethnic backgrounds and income backgrounds. And doctors said, at least as far as they knew, on a conscious level, they didn't feel differently about any of these patients. So we really wanted to study implicit attitudes, because we felt that maybe there was something going on that doctors didn't really realize they were doing. And so, I had been working with behavioral scientists and physicians and, other public health professionals and statisticians and so on and so forth. But at this point in time, I knew I needed to reach out to some other investigators in other disciplines. So I actually reached out to social psychologists to get a better understanding of how we measure implicit racial bias, and to see if we could kind of link that to the communication that went on. So we used the famous IAT developed at Harvard by Mazrin Banaji and Greenwald and Nosek, and we actually worked with Tony Greenwald, and gave the race implicit IAT to physicians in our study. We also gave another IAT, which is called the Race Medical Compliance IAT, to the physicians. And we looked to see whether the way physicians scored on these tests was related to the way they communicated with their Black and white patients. And lo and behold, we saw that about 2/3 of the physicians, similar to the general population, had implicit bias favoring whites over Blacks, and perceiving Blacks as being less medically adherent than whites by the race compliance IAT, and that their scores on those tests showed that the greater their bias preferring Blacks over whites, or stereotyping Blacks as being non-adherent, that was rated linked to poor communication behaviors. So things like basically spending more time on the strictly biomedical agenda rather than talking about the broader issues with patients, talking more slowly in a tone that was sort of lecturing the patient. And we also found that their African-American patients rated them more poorly, rated them as being less respectful, and actually had lower levels of trust in physicians who had more implicit racial bias. On the other hand, the white patients who saw these physicians rated them as being more respectful. So this really suggested that implicit racial bias was playing a role and was affecting communication. So what could we do? We're still working on this. Clearly, we haven't completely cracked this yet. And Dr. Williams, who will be talking with us later today, has been very much involved in a lot of this work, looking at changes in how we can change racial attitudes. But this was early on. And so what I was interested in doing at that time was seeing if we could actually get physicians to change the way they communicate. Even if we don't change their attitudes, maybe we could change the way they communicate. So we did a trial where we recruited primary care physicians and their ethnic minority patients who were living in economically disadvantaged neighborhoods, and they had hypertension. And so what we did was we had a randomized trial where we randomly assigned half of the physicians to get some computer-based communication skills training focused on being very patient-centered, not dominating the conversation like we had heard in our other studies, having a more balanced kind of conversation that wasn't only focused on the medical problem, but also on the broader social and psychological issues. So we randomly assigned half of the physicians to get that and the other half to just sort of get a monthly newsletter. And then among the physicians who had already been randomized, we randomized their patients to get a coaching program delivered by community health workers versus to just get, again, a monthly newsletter. And so the coaching program was delivered by community health workers, and it was really focused on getting these patients who were ethnic minorities and many of them poor to be more actively involved in their visits with their doctors, to be more prepared, to ask questions, to state their opinion. And what we found is that patients who were coached and whose doctors also had the communication skills training showed greater improvements in their information exchange with the physicians, more participation in their decisions. And if their blood pressure was uncontrolled at the beginning of the study, they were more likely to have controlled blood pressure at the end of the study, which was 12 months. So this was encouraging. We knew that we could do this, but again, this was a very small study and it was really people who volunteered to be involved. We didn't know whether, for people who didn't agree, which was about half of the physicians really, who weren't that motivated to work on this, how we could make this actually something that would become part of routine practice. So we knew we had more work to do. We also knew that physicians and patients don't operate in a vacuum, that there might be other things going on in the health system or other things going on in the patient's family or in the community that might be affecting their ability to engage in such a program. So we began to take a more ecological approach to health disparities research around this time. We knew that the field was now calling for multi-level interventions. So not interventions that would just tackle a patient, target a patient or a provider, but that would also look at some of the broader factors in the ecological model. That it might be that an intervention needs to target at least 2 levels, but probably 3 or even more levels in order to really have an impact on these important healthcare processes and outcomes. And this ecological model is specifically for interventions within healthcare settings, but you could apply this type of model to sort of any setting. So for example, here where it says healthcare processes, if we were doing an intervention that was in a school or in a church or somewhere else, these processes might look different. There might be different people who were interacting with each other in that setting. So for this particular piece, we wanted to look at these key interactions between patients and providers and other organizational members within healthcare. And we included community health workers because the research was really growing, showing that they are kind of a key influential force in connecting communities with healthcare. And we really came to know that we needed to look at a lot of different outcomes, not only clinical outcomes, but also to look at patients' experiences, to look at things like costs and healthcare utilization, because if we didn't do that, then how would we be able to convince people who make changes in practice and policy, because they wanted to know whether it would actually cost them more money to do things differently, whether they would need to deliver care differently. They need to know what resources they would need to implement in order to make this really happen. So we identified some key knowledge and translation gaps when we did a review of the literature that occurred at all these different levels of the model. And I'm not going to go through all of them. We identified about 15 of them when we reviewed the literature. And this was just focusing on cardiovascular disease and cancer. But suffice it to say that there were at least 4 knowledge and translation gaps that occur at every single level of this ecological model. And so one of them was that many interventions do not incorporate broad stakeholder engagement in the development of the intervention or the testing. So we know interventions needed to begin to incorporate stakeholder engagement much more. Many interventions don't test multi-level interventions against those that target a single level. So we really needed to be clear, do multi-level interventions actually work better? Intuitively, it sounds like they do, but we need more evidence for that. We needed to look to see whether you need a universal approach, to addressing health inequities, or whether you really need more tailored or targeted approaches. Believe it or not, sounds like it would make sense to have a more tailored or targeted approach, but nobody had actually looked to see what happens if you compare those things. a universal approach might improve health for everyone, but it might end up worsening disparities. So the other thing we found is that, a lot of studies didn't really look at specific implementation barriers and what are factors that would need to be put in place in order to sustain an intervention. How cost effective is it? And what would it take to actually make this something that could be translated into actual practice and policy use? So, I then began to focus more on how you close the implementation gap, because the health disparities field had grown quite a bit. And even though we still need to learn more about efficacy and effectiveness of interventions and some more about the basic biology of different approaches or even the epidemiology when it comes to different populations that have been understudied, we have a broad literature base and a lot of knowledge. And basically, one of the reasons we believe that we're not achieving equity is because we're not actually implementing what is known based on the evidence in practice. And so we really need to sort of close this implementation gap, involve people from more disciplines that can actually, make this happen, engage stakeholders more, get more involved in dissemination and translation initiatives. So really wanted to learn more about implementation science. And I don't know how many of you are working in that field, but it's really the study of methods to promote the integration of research findings and evidence into policy and practice. So we really we're not developing new interventions at this point, but basically we're taking interventions for which we have evidence. For example, we know that blood pressure medications can reduce high blood pressure, but how do we get doctors to prescribe those medicines, or how do we get patients to take those medicines when doctors do prescribe them? What are the barriers at the level of healthcare professionals, at the level of patients, at the level of organizations that lead to us not actually practicing evidence-based practice? And let's look at those bottlenecks and see if we can develop some approaches that would actually help people do things that we know work. So, and then also in order to do the appropriate intervention, we really need to involve communities more in this work. So I'm sure many of you are involved in community-based participatory research, which is really this collaborative approach that equitably involves all partners in all aspects of the research. So we really want people to be involved from the outset, selecting what problem to study, selecting what population needs the intervention, selecting what intervention approach, how should it be delivered, who should deliver it, how should we measure our success, and when we're done, how do we get the word out to other people? So all those things. And to do that, we really had to use relationship building principles. So it really came back to a lot of the things I was interested in with social relationships, things that I had learned about the doctor-patient relationship that really led to better outcomes. So building more respectful relationships, like how do people really learn how to recognize the humanity and the inherent value in each other? How do they build stronger partnerships and communicate more clearly with each other? How do they build trust? And how do they find concordance? Even if you may not have concordance on the sort of obvious things on the surface, but are there other things like values and beliefs that you can connect on that would help to make this partnership more effective? So I've actually been studying social relationships and academic partnerships as well. But in the meantime, really just using this approach in the work. So about 10 years ago, my colleagues and I were funded, and Dr. Williams actually was funded at Harvard to lead one of these Centers for Population Health and Health Disparities, funded by NIH. And we created this transdisciplinary research center focused on cardiovascular health disparities. And we tested 3 different intervention approaches. These were multi-level approaches to address hypertension disparities in Baltimore. So one project was focused more on health system level factors, but also broadened beyond that to involve community. One was focused more on the food environment, the 5+ Nuts and Beans trial, and trying to make sure people living in a food desert could get better access to food, working in partnership with a grocery store and having food delivered to a public library, and having a health coach to help people order foods that would have fresh fruits and vegetables and nuts and beans in them as a way to lower blood pressure. And then the third strategy, basically looking at different kinds of community health worker approaches to activating patients in a healthcare system. All of this was done in partnership with our community partners. And the center has actually evolved from a center that focused only on cardiovascular health disparities to broader issues in health equity. So over the last 10 years, we actually just celebrated our 10th anniversary last year. We are now called the Center for Health Equity at Johns Hopkins. So we not only advance scientific knowledge, meaning we do research, but we also train and educate future leaders, so researchers and practitioners and community advocates. And then we do all of this in partnership with our communities. We focus on cardiovascular disease risk factors, but we also focus on associated conditions such as diabetes, obesity, depression, and other mental health disorders. And we now are taking more of a life course perspective. So we have pediatricians who are looking at issues in childhood, childhood obesity, for example, and physical activity. We have people who are looking at the health of elders. We're looking at issues related to maternal mortality because we've broadened our faculty is now more than 42 faculty across the schools of medicine, nursing, and public health, and a 60-member community advisory board. So here's some photos of our community advisory board. Again, diverse stakeholders include leaders of community-based organizations, faith-based organizations, educational institutions, the public health sector, businesses, all of these people giving advice as to what they think is needed within their communities, what they can contribute, and how they think this research can actually be used to improve people's lives. So this has been a very instrumental part of our work, and we've actually done work not only in community engagement in Baltimore, but our model now has been sort of replicated in some of our other partnerships in other parts of the world. And I'll tell you more about that because I got reconnected to my roots in West Africa. So here are some of our health system and community partners at the moment. We partner with federally qualified community health centers, as well as the Johns Hopkins Health System in the Mid-Atlantic region. And we have local and national community partners. So I'll just tell you a little bit about our current trials. We have one trial called the Rich Life Trial. That is a cluster randomized trial in Maryland and Pennsylvania. We've enrolled 1,822 patients with hypertension plus another chronic condition. And we did that because our community advisory board told us that people with hypertension have other problems. And if you only focus on hypertension, you're really not helping the whole patient. And so this intervention really approaches the whole patient and addresses a lot of the other common medical conditions they have as well. We're comparing a standard improvement approach that only targets the health system to one that also incorporates a community outreach component. So there's a nurse care manager who works also with a community health worker to try to help patients address the broader social issues. And then we have a specialist team that can serve as consultants remotely, because we know that referrals to specialists are a huge access barrier for disadvantaged populations. So we're looking at blood pressure control and change in patient activation over time. And our 5 and nuts and beans for kidney trial is building on our previous work on the 5 plus nuts and beans pilot study, which showed improvement in the dietary intake of patients with hypertension, but not a dramatic improvement in blood pressure. So we wanted to really look at a higher risk group, which is people with early kidney disease. So we have a study that's now focused on that population in partnership with a local grocery store and delivery to a local location so that people don't have to worry about taking buses to get to the store to pick up their groceries. And then our final study is back in West Africa in Ghana. And we are using lessons learned from Baltimore and applying it to some clinics in Kumasi, Ghana, where we're actually testing community health nurses as supports to patients with uncontrolled hypertension, but also using mobile phone technology where patients can do not only home blood pressure monitoring, but they can enter that information into an app, which then is transmitted to the community health nurse. And this overcomes a lot of access barriers that a lot of these patients have because of living far away from clinics and also having transportation barriers and also, lots of traffic in West Africa, let me tell you. So we're going to be looking to see how this works there and taking lessons learned from there and bringing them back to Baltimore. So speaking of lessons learned, we've learned that multi-level interventions are a promising strategy to reduce cardiovascular health disparities, but there are several remaining challenges. So one thing is that, often it's hard to reach everyone that needs this intervention. So, we've really learned about that. And one of the reasons we're using community health workers is because they do increase the reach significantly. We learned between our first set of trials and our second set of trials that really addressing patient behavioral and economic barriers was critical. And so that's one of the reasons why we incorporated mobile phone technology and why we really incorporated more community health worker support in addition to the health system approaches. Tailoring interventions to context and person. We know that that's really critically important. And so we really need to sort of make sure we're assessing people's needs and meeting them where they are and not just using a one-size-fits-all approach. We need to really, a challenge is to align the priorities and incentives of stakeholders who may have different things that they're concerned about. Federally qualified community health centers may have other concerns around technology or around staffing, whereas a larger healthcare system might be more worried about, other issues, like, I don't know, their return on investment or something else. So we really need to find out what people's, what it is their goals and priorities are. And it's not always the same, and sort of try to, come to some understanding and common understanding and agreement. And we really have to start working at the very outset on how we're going to sustain these interventions if they are effective. So grant funding is not going to lead to a sustained intervention. So we need to build capacity in these organizations to seek external sources of funding. We need to, equip people to sort of advocate for themselves for changes in policy with payers, with other policymakers. We really need to work on how we get funding to engage communities, because a lot of times that is not built into our typical research funding, and a lot of the dissemination efforts are not built in. The study ends and the grant's over, and then how do we get the word out, and how do we begin to engage with other stakeholders to really implement these interventions? So, a few years ago, Dr. Williams and I actually were co-authors on this perspective, calling for a bold new vision of health disparities intervention research, in which we said we really need to reframe health disparities and inequities discussions. We really need to not focus so much on what people don't have in those communities, but really focus in on their strengths. Also focus in on the fact that a lot of the issues that lead to health disparities are not due to individual choices. Some of them are, but a lot of them are shaped by structural factors and opportunities. We need to design and evaluate more rigorous multi-level interventions using a social determinants framework and a health and all policies approach. So every policy has an impact, a potential impact on health, and we really should be thinking about those things in our education, in our housing policies. We really need to work on making sure researchers are more equipped to interact in an effective way with diverse communities. So they need to have excellent communication and cultural as well as structural competency, basically understanding about these structural factors and how they impact health in different communities. We really need to prioritize community engagement and equitably shared power, and then really foster transdisciplinary collaboration. So that's what we wrote about in our bold new vision. And now I'm going to just segue briefly to COVID-19 so that we can talk about the magnifying glass that's been shown on disparities. And so, this is where we are as of yesterday, 104.2 million cases worldwide, 2.5 million deaths, of which over 500,000 are in the United States, 20% of the deaths worldwide, whereas we are only 5% of the world's population. We have begun to administer vaccines, which is encouraging. But you may be asking, why are we representing 20% of the deaths in the world? And a lot of it has to do with our public health, our failed response, not only due to public health, because we certainly have tried, but our public health system has been sorely under-supported, and that's been very evident in this effort. But one of the reasons we're leading the world in these death rates and case rates is because we have very high rates of infection, hospitalizations, and deaths in our communities of color. You can see that the hospitalization rates are almost 4 times as high in many ethnic groups, and death rates are 2 to 3 times higher compared to whites. In terms of vaccinations, we're seeing inequities play out again. The race ethnic distribution shows that the predominance of people getting vaccinated are whites, and a much smaller proportion of Blacks and Hispanics and Native Americans relative to their representation in the overall population are getting vaccinated. So we really still have inequities playing out in vaccination. One of the things we've been doing at the center is studying the impact of COVID in our own population. And what we found is that actually these populations have different sources of information. Blacks tend to seek out most of their information from local TV stations, whereas Hispanics tend to seek out information mostly from friends. And whites have more sort of diversity in their sources of information. We know that health system mistrust continues to be higher in our ethnic minority communities, and that played out in our population sample as well. And what was concerning is that actually only about half of whites were aware that there are COVID-19 racial disparities, and only a third of Blacks and only 17% of Latinos in our sample were actually even aware that there are disparities in COVID-19. So, I've been working on a national level, calling for politicians to sort of do more to help the most vulnerable, tracking data, building trust with communities, enhancing access to testing and healthcare, and also to vaccines now, protecting essential and frontline workers, low-wage workers, because we know that they are overwhelmingly more likely to come from communities of color. And really in the acute period, providing social services, things like food and housing to our communities that are underserved. But on a longer term basis, like Dr. Williams and I have written about, is that we really need to focus more on addressing the social issues that have shaped inequities for so long, that we really need to have more comprehensive and coordinated investments in social determinants, and that the failure to do this doesn't only harm them, but harms us all. And so we called for a new kind of herd immunity that is not just a biological herd immunity from a vaccine, but that is protection that we can offer our entire country from negative social factors. And so I'm going to close because I know I'm running out of time, but Dr. Williams and I talked about using what we already know to take action. And we can talk about this in the Q&A section, but we talked about creating communities of opportunity. We talked about building more health into the delivery of healthcare. And we talked about raising awareness of inequities and building political will to address inequities. So those are the three broad strategies we've called for, and we said that once we do that, we will really be able to embrace this vision that we have of health equity. So I'm just going to close with an African proverb that I often quote that says, if you want to go fast, go alone. But if you want to go far, go together. We have to do this together. It's not going to take one person to solve this problem. And as Dr. Michelle Williams mentioned, I have a book coming out in June. So look out for it, and go to Amazon.com and put your pre-order in. So thank you.
Well, thank you. Thank you so very much, Dr. Lisa Cooper. It's been a privilege for us to have you here at the Chan School today, and thanks for such a comprehensive lecture in terms of the challenges we face and what we can do about it. This is a time for audience participation. Please put any questions that you have in the chat. There's a Q&A section. Why don't we use a Q&A section instead of the chat? And I will see how many of these questions we can get through quickly. Let me begin, Dr. Cooper, with one question. You talked early in your career about doing research on implicit bias, on racism. And the question has to do with what challenges did you face, did you have to overcome in doing research on racism? I think the question is assuming that healthcare providers didn't like the idea that you were talking about racism within medicine.
Well, that assumption is absolutely correct. I don't know what I was thinking, but I guess I thought, well, I mean, there's a problem. We need to figure out what it is, because if we don't, we can't do anything about it. And I knew a lot of my colleagues weren't intentionally treating patients of color differently. So, one of the challenges I had, honestly, is that study about implicit racial bias actually took 4 years to get published. It went to several different medical journals. We had to do all kinds of different analyses. We had to stratify by all kinds of different factors, adjust for everything you could possibly think of. Some reviewers said that maybe it was patient bias that was driving the findings. And so, I faced a lot of challenges. The point was just to be consistent, to be very rigorous in my approach and scientific. I tried to, as much as possible, although I knew that I had some of my own biases, but to really bring in people who have different perspectives and to, again, like I said, use the most rigorous approach possible to answer the question. And to, once we have the answer, to really make it clear that, implicit bias is something that is inherent to being human, and that it's sort of the way our brains work, and that it doesn't say, it's not a moral statement about someone. And so, after persevering for a while, I think Dr. David and I were at a conference where it was a conference on racism and discrimination in health, and there was a special issue of the American Journal of Public Health that was requesting papers. And so the paper finally got published in a journal of public health, not in a medical journal, but now the medical journals are talking a lot about this. So you just have to persevere.
Times have changed. Another question. When the evidence and data do not influence or move stakeholders to change their attitudes and actions, what are effective ways that members of the public can use to lobby for structural and systemic change in order to advance health equity?
Wow. So yeah, that is a tough question. I think people in communities that are impacted by disparities, what we can do to actually help them is to give them the information and give them the tools so that they understand the problems and they can advocate for themselves. They can use their own voices and their own public engagement, and they can go to the ballot box and vote for people who are more supportive of policies that will enhance the quality of their lives and their health. So I think the best thing that we can do is to try to empower people from, those communities. And also we can use our own voices as well to speak for people who may not be in those rooms that we're in. But also share that knowledge with them and encourage them and to do that work, because I think by them using their own power, the power of their voice and their votes, they can bring about that change and help them to see that.
Another question, could you elaborate on how Brown and Black communities receive information such as the local news, and what are some ways to mitigate this and encourage a broader vessel of sources of information?
Yeah, I think this population that I studied was an older population. The average age was 60, so this doesn't necessarily represent all people in communities of color. In fact, there's national data suggesting that actually that Blacks and Hispanics are very much involved in social media. So I think social media is an effective way of engaging with these communities, as well as radio stations and local TV stations. I think people need to see people who look like them and people that they trust talking about these issues, and I think that will help a lot. I think we need to just find out, it's not going to be one thing that works for everyone. Again, some people might respond to text messaging or phone calls from people they know. Other people might be looking to a celebrity or somebody else to help to change their perspective. And yet other people might just prefer to have a good conversation with their own doctor. So I think we just have to understand that it's not going to be a one size fits all approach, and that we have to try lots of different things.
Another question, how can we address systems of patient mistrust with providers? So I think it's addressing the problem of patient mistrust, but systemically.
Yeah, well, I think, I've been writing about what health systems can do, and actually wrote an article recently in the New England Journal of Medicine Catalyst, which is a new publication that focuses on health practice and policy innovations. One of the things I said is that organizational leaders need to be clear about their mission, about making sure that the patients they serve know that equity is part of their mission. and that they shouldn't just say it, but they actually should have things that make it visible that they are committed to it by, for example, having leaders who are represent these diverse communities, who are on their boards. They should pay the people that work for them who are from these communities a living wage and give them benefits. And they should be involved in partnerships with community-based organizations. And that's what we call walking the walk and not just talking the talk. And I think that's what builds trust. I don't think just saying things is going to build trust. I think putting in place training programs for your staff and your clinicians is good. And I think that may help to improve skills and build relationships within the healthcare setting. But I think it goes beyond, like I said, it's those other organizational practices that really show people that you're walking the walk.
Another question for you. You have had a remarkably successful academic career. What advice would you give to students in public health today, especially students of color, in terms of what are the keys to success in academia?
Wow. Okay, so I guess one thing I would say, I'm going to invoke Dr. Martin Luther King again, because he said, all work that uplifts humanity should be done with painstaking excellence. And I think that's what we really have to focus on, is we have to be excellent in what we're doing. We have to be very rigorous in what we're doing. We have to bring all of our scientific expertise and our clinical expertise into this work. And we have to do it in such a way that it's impeccable. And when we do that, I think it's going to be hard. People will still scrutinize us, no mistake, but I think it'll be hard for people to argue with that, with the naysayers. I think we have to look for allies, I think, within the academy and without, whether it be among colleagues or people who are community oriented and who are also like-minded, and rely on those relationships to strengthen us and encourage us to continue to move forward. So I think those are the two things I would do, is say, focus on excellence and rely on your relationships with colleagues and with community partners. And finally, well, take care of yourself, because you can't be a social justice advocate. You can't save the world if you don't save yourself. So practice what you preach.
I think we have time for one last question. And that is, what do you think we need to change in the training of medical and nursing trainees, and I guess other people in the health workforce, to better prepare them to address health disparities and serve all communities?
Yeah, I'm glad you asked that. I think there's been a shift in a lot of the training of health professionals to include factors that are broader than the strictly sort of biomedical ones. Over the years, there's been more of a focus on behavioral factors and more on sort of doctor-patient or patient-client relationships. But I think increasingly we need to really educate people about structural factors, racism, and other structural factors and social determinants, and how they play out and how they affect people's ability to engage in healthcare and to be healthy. And so when we get a better understanding of that, and we gain some skills in how to better engage with our partners outside of healthcare, I think we will be more effective at delivering the care that's appropriate for our underserved populations.
Well, I would like to say to everyone, please join me in saying a big thank you to Dr. Lisa Cooper. This has been an amazing Yerby lecture today. And we really appreciate the time that you took to spend with us and sharing so much of your wisdom. Thank you so very much. And thank you everyone for participating in this program today.
Thank you for having me.